The core to everything that's different about this is at the center of CPR, whether that's chest compressions alone, whether that's supported airway, bagged, intubated, or the combination of compressions and airway. That procedure of CPR is an aerosolizing procedure from a definition standpoint. Aerosolizing procedure means airborne precautions, so face shield N95 and the gown gloves. So the surprise codes are going to be mainly cardiac, probably. They're going to be inflammatory, ischemic, cardiac, VT, VF, myocarditis storylines, or they're going to be related to the thrombotic risk in these patients. Okay, and it's going to be a massive DVT that goes upstairs to a PE and becomes a sinus tach PEA arrest. Okay, those are going to be the two most common storylines, I think. In those situations, the team that's first here is probably not going to be in airborne precautions. They're going to be droplet people. The first person in then will be in droplet. Walks into the room when this patient codes. The key is that they can't do something that aerosolizes. So they can't do chest compressions, they shouldn't bag. Okay, so what's that first person in the room going to do that's useful? First person in puts a mask that delivers oxygen, whether that's a non-rebreather, great, if they're in shortage, whether it's Venturi, whether it's whatever, is fine, but it goes over the face and the oxygen gets turned up maximum, and then over that oxygen delivering mask goes the surgical mask. That combination is going to provide passive oxygenation plus a pretty darn good aerosolizing barrier, okay, with those two. It's going to be really tempting then after that first person in there does that to want to start chest compressions, but they can't because they're in droplet. Okay, so the second thing that person does is the defibrillator hopefully is there by that point, comes into the room, and they should hook up the defib, okay, and get ready to shock. At least in a subset of these that are going to be VT, VF, that's what we need to do.
And then we need, is the code card here yet?
Yeah, give just a second. The defibrillators here. And if someone else wants to come in and droplet, they can, but anyone else that's coming in comes in airborne. So there's two people.
Okay, so defibrillator gets set up, and then by that point we should have 2 or 3 people there in this code. We're still not doing chest compressions because there's people in the room in droplet only precautions. As the rest of the team arrives, the code team should not go into the room without airborne on. Okay, they should take the time to get it on and go in once, because if they go in with droplet, they're going to come out to put airborne on and then go back in, and it doesn't make sense. Okay, the first resident in, go to the foot of the bed and run the code. The second resident should pick up a walkie-talkie on top of the Lucas cart and go in with the walkie-talkie. That second resident becomes the door person. Okay. And then the third resident who comes should drape the 2 ultrasounds. Okay, and that third resident stays outside of the room. There's quite a potential that we'll say we need another resident in here. If that happens, great. But that third resident's going to stay outside of the room.
3 nursing roles are going to go into the room in airborne, so you're going to have 4,200, PV20, and 1 rapid nurse in the room. You guys can function in all 3 roles, so just communicate well at the start who's doing what. You want a recorder, a med nurse, and a defibrillator, and then you want someone or a couple of you to help, along with one of the RTs, put the Lucas on ASAP. 2 RTs in the room are going to be doing, when it's safe, to the bag mask ventilation with the filter. But 1, if you can help put the Lucas on.
Once there's enough people in there in airborne to do chest compressions and do supported ventilation, so it'll probably be 3 people, have come in airborne, The code team leader needs to say, we're going to aerosolize this room. Everyone in droplet needs to get out. Okay? And once you've said that, and once you as the code team leader have assured that happened, then you can say, start chest compressions and start bagging that patient.
Everyone in here airborne?
Yep.
All right, go ahead and start compressions and let's apply to Lucas.
We get stuff for the airway.
Everyone's out, and then this runs as a normal code. Okay, everyone that comes in will be in airborne. The room will be airborne until the story is over. It will never go back to droplet only. The roles then of the other people who arrive, pharmacy will arrive. The carts aren't going in the room. So the people who support those carts are not going in the room. Pharmacy will stay outside, will work the top drawer. The resident who's inside the door, okay, the door will be closed because it's an aerosolized room. The resident who's inside the door will have a walkie-talkie or will have a small opening here. And we need one of epi will come from this resident to pharmacy, and then epi will go in. Lucas is here, okay, hand me Lucas. Lucas will go in. Meds will go in and out through the door. And whether the door is closed or is like this, okay, I think that risk is similar. Okay, ideally it's closed, but this is worse. Right, you felt that air, probably hit you over there, right? So the opening and closing of the door needs to be a really small opening and closing, not a full waft of air that flies through the entire unit when that happens. So that resident is passing stuff in and out of the room and communicating out either through the door that's cracked open or with the walkie-talkie. The walkie-talkie to work is going to need a really quiet room. So more than ever, code team leaders and support just need to say the room's got to be quiet. Because that communication outside of a room, especially these ones where you can't see in, really has to be quiet to get that done.
It does, yeah. Oh, okay. He's not using it because. Did he show you that? He's right by the door and I'm right here, but I could leave this.
We're here for bicarb.
Kinda out of. Last time.
Sure.
I think that's a good idea.
Get a norepi drip prepped.
Lucas is going to be put on really soon, okay, as soon as it comes. We often delay Lucas a little bit to see, are we really going to need this, or are we going to get him out with one more shot? That can't be the story here, because the biggest PPE exposure risk to the code team is going to be someone doing manual compressions on top of a patient with PPE and face mask and N95 coming loose down here every time, okay? So as soon as Lucas comes to the code's got to take a pause to put it on, okay? You don't need to disrupt a stack, the first stack to do it, but don't wait to put on Lucas. It should go on so the manual compressions end.
Okay, I've got the Lucas.
All right, let's apply to Lucas right away. Yes, minus that. Heart failure. So we'll treat this as PEA, and let's get an AF of epi in here.
Anesthesia's here. Okay. Epi given.
That's coming down.
Alright.
Can we get a leader on pressure bag, please?
Alright, there's the spiders.
Let's get the ultrasound in here. We're gonna treat
Yeah. You're gonna do drugs, I'm gonna do defibrillator.
The critical care physician will provide intubation support if anesthesia is not available. They will perform as the proceduralist within the code, and otherwise will act as the code whisperer in a supporting role to the code team leader.
All right, let's pause for rhythm.
Okay, everybody
So
clear?
VT shock, please.
Shocked at 300.
Okay, charge to 360. Hold. Check for a pulse. We got a rhythm change.
Pulse.
You have a pulse. Okay.
Strong radio.
What questions came up in there? So if it's in the unit and everyone's already in airborne, It runs like a regular code. There's not this strange compressionless period of time with droplet folk in the room. So nothing from that standpoint is different if people are in airborne. It's great. Good. The communication in and out of the room really has to be meds with doses and routes. There's going to be med errors, right? If the code team leader says we need epi, the person at the door says let's do one of epi, and then something comes in and it gets handed to someone else. There just has to be 100%. This is 300 of amnio bolus IV that comes into the room. Route and doses has to happen. You can tell in the room that it's hard to hear. Once people put on pappers and half the room's got pappers and half the room it's got something else and everyone's got masks on, it's really hard to hear. So people have to be quiet in there. The code team leader has got to really try to do that. And that's part of the reason of keeping anyone else out that doesn't need to be in there, which is the door person's job in the room. So loud orders when they happen, louder than normal, and the room has to stay quiet. Good. So everything that goes into this room stays in that room when it's done. The exception would be Lucas can come out and get wiped down, but everything else should just stay put. And then 10 people who aren't in airborne shouldn't go in there to clean up. The room is aerosolized, depending on where you are, for 30 or 60 minimum minutes after this finishes. So the room is an airborne room after the code, as well as during it.
All right, let's talk about a couple questions that come up frequently. If you are coming to a code and you forgot a piece of PPE, keep coming. We'll have PPE at the code for the code team. If you forgot your face mask or something, or your face shield, keep coming. Other question is for all the folks outside of the room who are part of the code response but are positioned outside of the room, not in the room, what PPE needs to be worn by those people? The answer is they should be wearing whatever PPE they arrived at the room in. Specifically, they don't need to upgrade to enhanced airborne to stand outside of the room in the hallway. One piece is anyone who's outside of that room needs to have gloves on. If blood gets handed out, if supplies get handed in and out, anyone outside of the room does need to have gloves on. They don't need gowns, etc., but they should have gloves on in addition to the PPE they arrived in. All right, let's talk a little bit about bringing additional people into the room, specifically lab and EKG. I want you to think really hard as to whether it's going to be impactful for what's going on in the room before you just order a rainbow of labs, which we often do in codes. If you decide that labs are needed, then the first step should be to ask the room as the code team leader, is anyone in the room able to draw blood? If the answer is yes, great. Then it can be drawn by someone already in PPE in the room and can be handed out to be run outside of the room, whether that's ISTAT or being sent to lab. If it can't be drawn by someone in the room, then lab should come into the room at that point, but should not just come into the room empirically for these codes unless they're requested in. The same thing should go for additional services like EKG. Think really hard whether or not that's necessary, or X-ray, whether that's necessary, especially in the setting of ultrasound in the code. Those are going to be infrequently needed and involve bringing an additional person in. During the code, people are going to get their PPE disrupted or knocked off, and the risk to you in the room, if you get your PPE knocked off, is very low from a standpoint of just existing in the air of the room. The risk to you if you have your PPE knocked off is going to be taking your dirty hands and trying to readjust and put back on your face mask without doing hand hygiene. So the process, if your PPE is disrupted during the code, is to walk to the door. At the door, anytime you go in and out, you're going to drop your PPE from the neck down, so your gown and your gloves come off in the room, and then come out of the room with your above neck PPE in place. And then just pause for a second, think, slow down, clean your hands, and readjust your PPE before you go back in.
You can tag out with someone who's outside the room to exchange roles at that point. But the biggest key is just don't try to get your PPE put back on in the middle of the code while you're in the room without doing hand hygiene. And coming to the door and coming out is probably the smartest way to do that. Okay, so at the end of the code, if the patient needs to be transported, what's the procedure there? So code team members who are transporting this patient need to have on clean contact PPE. So if you're transporting the patient, you should take off your gown and gloves and put on a clean set of gown and gloves. Your neck up PPE can remain on as it is for transport. Patient will get a new gown and a clean sheet over them. And then that patient can be transported. The airway in a patient moving down the hall either needs to be spontaneously breathing with a appropriate mask over that patient, or the airway needs to be secured and being ventilated. So no CPAP or BiPAP or bag valve masking without a secured airway while patients are moving from one location to another after the code. All right, that's not a comprehensive overview, but that is a lot of the high points around how to approach the differences from the typical Allina in-house ACLS protocols when we are resuscitating patients with COVID-19 or PUIs. This was, again, filmed at Abbott Northwestern, and some of the aspects of this video are specific to the code response at Abbott. So some things like who is filling the roles and what equipment arrives at codes will differ from site to site within the Allina Health system. But hopefully the rationale and the demonstration of some of these pieces is applicable across all of the Allina Health sites.